Good evening, everyone. I'm Dr. Catherine Hoyenter. I'm a Senior Research Fellow at the Centre for Women's Health Research here at HMRI. On behalf of everyone at HMRI, I'd like to welcome you to our second Community Health Seminar for 2021 from the comfort of your home, our live audience, or wherever you might be joining us from. Before we begin, I'd like to acknowledge the traditional custodians of the land on which I stand, the Awabakal and Worimi nations, and pay my sincere respects to elders past, present and emerging, both here and from wherever you're viewing. Thank you for joining us. We've had just over 330 people register to join us virtually tonight, and our first live audience for a year, so welcome to you and those watching on catch up too. Tonight's community seminar, our second one for this year, will focus on women's health research. Tonight we put women's health and wellbeing under the microscope at our community seminar. We'll hear from HMRI researchers Professor Deborah Loxton, Dr. Nicole Nathan and Emmalee Ford, as we look forward to look at women's health across all ages and what the research is telling us. We'll discuss fertility, reproductive health and wellbeing, healthy ageing and the factors that influence women's long-term health, and the health issues that women face today. We've allowed time for questions, so please send them in via the question function on Zoom to us throughout the event, and we'll collate them and endeavour to answer as many of them as possible at the end. So to start, I'm delighted to introduce our first speaker tonight, Dr. Nicole Nathan. Dr. Nathan has more than 15 years' experience as a health promotion manager for Hunter New England Population Health. She specialises in implementation science in health policy. Having worked across multiple Hunter New England health programs and projects, she knows just how policy workers and researchers can ensure that they don't fall short on making real and measurable changes within the community. She's currently studying the impact of school uniforms on female participation in physical activity in school. Welcome, Nicole.
Thank you for that. So good evening, everyone, and thank you for giving me the opportunity to talk about a topic which I'm extremely passionate about, which is girls' physical activity. I'd like to acknowledge that we're meeting on Aboriginal land and pay my respects to elders past, present and emerging. I would also like to acknowledge my incredible team of public health researchers and practitioners at Hunter New England Population Health, some of whom are in the audience tonight, whose research I'll be presenting tonight. Just spoiled the surprise. So I'd like to start with a quick activity. So it's nothing interactive, you don't need to panic, I'm not going to get any volunteers out the front. But I'd like you to imagine yourself running. Now you might be a person who runs every day, or you might be a person who hasn't run for a long time, that's okay. But I just want you to close your eyes and imagine yourself setting out from your front door and starting to run. I want you to look down and see the path beneath your shoes. See your knees coming up toward your chest and your heels extending behind you. Your arms are relaxed by your side as they swing forwards and backwards with each step. You start to get into a bit of a rhythm and you feel your body relax. As you continue to run, you feel the perspiration on your forehead, back and chest. But you're not hot. Your clothes are loose and you are cool. You feel comfortable, confident and strong. Now, as you open your eyes and look at the pictures on the screen, I'm going to assume that no one imagined themselves running in something that resembled this. So our team have been asking, is it reasonable to expect children, particularly girls, to be active at school in these types of clothes? And thanks to funding we received through Hunter Children's Research Foundation, we've been investigating how school uniforms impact on girls' physical activity. But this is a women's health forum, so why am I talking about children's physical activity or girls' physical activity? So for those of you that heard Narelle Ether present a few weeks ago, she did a fabulous job on talking about the benefits of physical activity, in particular high-intensity physical activity across the life course. So very briefly, we know that adequate physical activity in children provides a number of benefits, improving their physical health, their social health, cognitive and mental health. And so as a result, the World Health Organization, as well as a number of jurisdictions internationally, including Australia, have developed physical activity guidelines for children, which in Australia ask children to accumulate at least 60 minutes of moderate to vigorous physical activity each day, and to include some strength, muscle and bone conditioning in that in at least 3 days per week. But what we know when we look at objectively measured physical activity is that Australian children, and as is the case worldwide, that most children are falling well below these physical activity guidelines, with only around 15% of children meeting these guidelines. And so whilst it's a concern for both boys and girls, when we look at population data, we see that girls are significantly less active than boys. They are less likely to meet physical activity guidelines, and they are less likely to have developed proficiency in fundamental movement skills like throwing, catching and kicking. And as a result, we see a huge decline in girls' physical activity from a young age. Now, as a female public health researcher and a mother of 2 girls, this is just completely unacceptable to me, because we know that childhood physical activity is a critical time in developing habits that will track into adulthood. So if we don't have girls from a young age that are active, that have developed habits, that have developed skills and a love of movement, then they are less likely to be active adults, which significantly increases their risk of developing a number of chronic diseases, including cardiovascular disease, type 2 diabetes and some cancers. So for the last 15 years, our Good for Kids team have been trying to support children be more active by ensuring that the environments they live in are more conducive to physical activity. And schools are obviously one of these settings, because they provide us access to most children, they have the infrastructure, and they have amazing teachers who are experts in delivering age-appropriate programs to children. And I do want to acknowledge our schools in the Hunter New England region, because their efforts in implementing our Good for Kids programs is amazing, but their willingness to participate in research which has enabled us at Population Health to identify effective programs that can be rolled out as service delivery across the Hunter New England region has been immense. So we're very grateful to our schools for their participation in our programs. But anyone that has worked in schools or with schools know how busy they are. Our schools are under incredible pressure to deliver a very packed curriculum. They have all kinds of social issues that they're expected to address. And then when we consider fires, floods and a global pandemic, we understand them saying, we cannot do any more at the moment. And so we have been aiming to identify simple, scalable physical activity programs that schools can implement that don't require a whole lot of time or resource. And so, for example, we've been working with schools to support the implementation of energizers, which are just short, 5-minute, high-intensity physical activities that they can do in the classroom. You can see here they're following on with a classroom video. And it just breaks up sitting time for the children so they can sit back down and concentrate more on their work. But the work I'm going to present on tonight is our work on school uniforms. So what do we know? Well, for anyone that has attended a school in Australia, you would be familiar with school uniforms looking something like this. So this is me in kindergarten at Blaney Public School, circa 1983. And this is my daughter in kindergarten in 2017. And besides the fashion faux pas of my socks there, you can see that in almost 40 years, uniforms haven't changed. Tunics, socks, black leather shoes. However, we know that in 40 years, children have changed. Their body compositions have changed, their views on body norms, their modesty, fashion, it has all changed. And so our team have wondered, what if students could simply wear their sports uniform, which resembles something like this, every day, which they currently probably only wear 1 day a week on sports uniform day. It's simple and inexpensive for schools to deliver. It requires no ongoing resource for schools. There is no time, effort or skills required of teachers. And regardless of staff turnover, it will continue. And so it helps overcome all the challenges we know schools face when they're trying to implement physical activity programs. And as a public health researcher, it offers a very simple, scalable intervention that we can see every child in every school receive. So what did we do? Well, first we had to find out if children would even want this. So we surveyed about 1,000 primary school students and 1,000 secondary school students, and we found that a large majority were happy to wear their sports uniform every single day. And almost 2/3 of primary school students and the majority of those children who said that they were happy to wear their uniform every day thought that they would be more active if they were wearing those uniforms at schools. And we saw an association in the responses with girls, especially as girls aged. Now, these findings are consistent with research that's recently been published by Claire Hanlon in Victoria, who surveyed over 700 12 to 18-year-old girls around their preference for sports uniforms. And she found that 90% of girls just wanted to wear shorts and a t-shirt when they're being active. Now, given physical activity significantly declines as girls age, I think we really need to listen to what girls are saying they're going to be more comfortable and confident in wearing when they're active. We then went on to survey approximately 1,200 parents, 600 teachers and about 50 school principals. And we found that almost 80% of parents and 60% of teachers were supportive of a sports uniform policy only. However, principals are going to need a bit more convincing. So when we asked what their biggest barrier to implementing a sports uniform only policy, overwhelmingly principals said they didn't think it was appropriate for formal occasions, which I can completely understand. So perhaps we need to work with some sports companies to try and design sports uniforms that are a little bit more smart, that could be worn for formal occasions. Our last question was to determine if it actually made a difference to children's physical activity. So to do this, we randomly allocated 42 primary schools, where half the schools were asked that their students wear their normal sports uniform just on a one day of that week when they'd normally wear their traditional uniform. And the rest of the schools, we said, just carry on with your normal practices. We measured student physical activity using an accelerometer, which is the picture on the screen, which is just like a watch that the students wear on their wrist, and it measures the intensity of activity that they're doing. So we know if they're walking, running or sitting. And they wore that accelerometer for one school week. And we compared that day, the day when they were wearing their sports uniform, to their normal usual days, excluding their sports day. And overall, what we found within those students, within just the intervention students, was small but significant impacts within intervention students' physical activity. Now, this study had lots of limitations. It was only one day. We only looked at children in grades 2 and 3. We didn't look at physical activity outside of school. But these small changes did give us some hope, because the results, firstly, were on par with what some other more complex, costly school-based physical activity interventions have found. But also what we know is at a population level, even modest improvements in children's physical activity could have important public health impacts. So what next? Well, first I need to acknowledge that since this study, some schools have actually changed their school physical activity policies, and some children are allowed to wear their sports uniform. However, what we're seeing probably a lot of is that schools are allowing girls to wear shorts, but they're mostly either tailored shorts or skirts. And so we think that there's still some work to be done. There's still maybe some work to be done in convincing them that all children would be more active if they could just wear their sports uniform. And so on the basis of our pilot study, we've received funding to now test this more rigorously, and we're about to undertake a larger randomised control trial in 24 schools. And so schools that currently have a policy where children have a normal uniform and a sports uniform, we were going to test that if those children just wear their sports uniform every single day, does it improve their cardiovascular fitness and their physical activity? So we will provide children in grades 4 and 5 some additional sports uniforms from their school so that there's no cost to parents. And we're going to do a much longer follow-up at 12 and 18 months. So if I can do a bit of a plug, if there's teachers or principals from schools in the Hunter New England region who are keen to participate, please let us know as we're starting to recruit schools now. So what we are hoping is that if our largest study sees some improvement, even moderate improvement in children's physical activity, that we can use this to try and influence school policymakers to consider changing school uniforms to be around more activity enabling. Before I finish, I'd like to acknowledge our funding agencies, in particular the Hunter Children's Research Foundation, who funded the pilot work, as well as amazing teachers, principals, schools, children, parents who participate in our research programs. It's very much appreciated. So thank you.
Thank you so much, Nicole. I think that was a wonderful example of a really simple yet powerful change that you can make to the health of women and girls. So next, I'm pleased to introduce our second speaker for tonight. Emmalee Ford recently completed her PhD with the University of Newcastle, where she looked at underlying mechanisms for how eggs grow and how they're lost in order to provide new directions for diagnosing people at risk of early fertility loss. Throughout her PhD, Emmalee also focused on what the public knows about fertility, including the study of reproductive health apps that track menstrual cycles. She believes that apps have an important role to play in understanding fertility, but there's much more work to be done. Welcome, Emmalee.
Thanks for that, Kath. So today I'm going to talk about the research that I've been doing about why I think sexual health education needs to move beyond what it is now and include fertility. So the current sex ed curriculum has been described as bugs, babies and bodies. And that was by Tamsin Griffiths, who was a high school student in Victoria who actually did her own research about what young people wanted in sex ed. And her results actually were similar to a study done a few years ago that found that around 40% of Australian students are unhappy with sex ed right now. If we want to talk about changing sex ed, there's so many different voices we need to hear. And similar to what Nicole was saying, it takes a lot to make a change. Some people say education's a federal issue because of the national curriculum. Some people say, well, it's a state issue because they control how the curriculum is taught. Then we have to think about independent and religious schools. So what ends up happening is we have around 80% of young people using the internet to get their sexual health information. So I want to know how we make sure their access to this information is safe and reliable, and how can we teach students what they need to know in a way that's culturally and socially relevant to them. And that's what I hope to cover today. The reason we need to change it is because what it means to be a young person is changing so fast and we need to keep up. But it's hard to balance what they need to know right now with what we think they need to know throughout their lives or many years later. Some things are working in sex ed right now and some things aren't. And I want to give you an example. This is the rates of STIs in Australia over the last 30 years. And in the last 10, chlamydia has tripled. So that's not doing very well, whereas other STI rates have stayed relatively the same. So the good news is that teenage pregnancies have dropped 40% in 10 years, with only 2% of mums in 2018 were teenage mums. When we compare that to, in the same year, 1 in 20 babies were born from assisted reproductive technologies like IVF, typically used by people who are struggling to conceive. The darker side of this is that only 18% of those treatments were successful and resulted in a baby. So these numbers could be much higher if the technology was better. When students were actually asked what they wanted in sex ed, they want things like sexuality, inclusivity, consent, and safe sexting. Now to talk about fertility. 1 in 6 couples experience infertility in their lives, but this disproportionately affects the childbearing partner. And this is due to a lot of reasons, but typically it's to do with the role that women play as mothers in developing a child. So we know that the age of the mother is a really big contributor to infertility in Australia, and we've seen this by the rise of first-time mums going up over the last 20 years, and around a quarter of mums in 2018 were aged 35 and over. And from 35, fertility sharply drops, and there's a few reasons for that I'm happy to talk about later, but it's important to know it's harder to get pregnant in this age and stay pregnant. So when women were actually asked when they were receiving treatment for infertility, they said they wish they knew more about fertility earlier on, and it would have helped their current situation. And that really speaks to me about, the goals that I have and what I'm trying to achieve. So what do women know about fertility right now? I think that's really important when we want to consider what we can do to improve it. I did a study last year, and I surveyed over 650 women, and found that 41% didn't know the most fertile time in the menstrual cycle, which is important if you want to get pregnant. 35% didn't know the risks that smoking and obesity could have on fertility. Only 44% knew about this fertility decline from 35 years of age. And shockingly to me, only around a third understood that relatively low success rate that assisted reproductive technologies can have. But it's not just Australians that have these problems. Data from 26 countries shows that for both men and women, fertility knowledge is low to moderate at best. So why do I think it's really important that we know this? Well, from this data, I would say by overestimating the amount of time people are fertile and having that idea, and then having a misconception that ART can cure the infertility, it leaves a lot of people facing childlessness, which is a really terrible situation to be in. So can we teach fertility in schools? Well, the United Nations UNESCO recommend that sexual health education should include fertility, but this isn't mandated in the Australian PDHPE or biology curriculum. All I could find were these two little dot points. One was about comparing reproductive systems of organisms, which to me is not really relevant, and the other was about researching reproductive technologies to find out how they rely on scientific knowledge from different areas of science. That's more of a technical question, an understanding of science question. Doesn't really leave kids into knowing why is fertility important, why were these technologies invented, and why are they still used today. So what I'm going to do is talk to young people to find out what they know about fertility and what they think needs to change. So if we have their input, I think when we develop a resource, which we're working with family planning, it'll be more likely to be absorbed by young people. And our idea is that teachers will be able to teach this along with their normal class, and it will include fertility. So what can we do right now to improve fertility knowledge? As I said before, the internet is a really important place where people get information about health and fertility. People go there before they go to the doctor. They don't normally look past the first page of search results. And so we've seen pushes from the World Health Organization to really improve our e-health or online health services. Some colleagues of mine did a study last year, and they looked at all the information online someone might come across if they were trying to conceive. And they found that over thousands of web pages, 40% of the information was inaccurate, which is really concerning for someone who's trying to use that information to get pregnant. I think apps are a really great way to remedy this because they're very widely used. 99% of young people have smartphones, and 7% of all health apps in the App Store are to do with female reproductive health right now. People use these apps as a part of their everyday life to track cycles, to plan pregnancies, to record or monitor their symptoms, use as a natural alternative to contraception, and many more reasons. And apps have actually helped us redefine what is normal in menstrual health, because app companies can give scientists their data to understand women, and they've found that only 65% of women have this normal 25 to 30 day cycle. And they found that menstrual cycle can influence women's moods and emotions much greater than many other factors, except Christmas, where everyone was unusually happy. So what I'm trying to do is find out where women get information about fertility and if apps help them. I actually launched a new study, so if you meet the criteria, take a photo of this slide with a QR code, visit the link, or come and see me afterwards. I'd love to hear from you. So we did a similar version of this study that I talked about earlier, and what we found was that women who use reproductive health apps were almost twice as likely to know the most fertile time in the menstrual cycle compared to women who didn't use apps, which really interested us because we want to find out now if apps were the cause of that knowledge, and regardless, we know that apps are really important and many people use them. So now if you want to go and get an app, you might have many different reasons that you want to use one, and that's fine because there's many different options. But when you open the App Store, this is what you see. That's something that we call pinkification, and to me it's kind of insulting, even though pink's my favourite colour. A lot of girly, flowery, love hearts, and that to me is one of the first things that needs to change. So what are apps like right now? Well, some Australian scientists looked at apps available in Australia, and they found that only around 40% could correctly predict the ovulation date. Less than 20% of pregnancy apps could give a correct baby due date based on data they got. And less than 10% gave references for the claims that they used, which is really concerning to me. So if anyone in the audience actually uses an app right now and you're worried, well, I have some tips for you. So think about who made the app and who is it for. Is that person you? Ask why you're using the app and what you need it for. And if the app isn't meeting those needs, find out what you need and where else you can get it. But be careful if your app makes claims that you can't verify and you don't know where they came from. Fortunately, there are solutions. I think there needs to be a verified app from a source like Family Planning, a university, or New South Wales Health, for example, where people could get free, personal, and reliable information. I think there needs to be guidelines for how contraception and conception apps market their effectiveness. And I think there needs to be, for my benefit, transparent algorithms and content so scientists and health professionals can actually evaluate these apps easier to give recommendations to people. It's actually so hard to do right now. So this is my vision for a fertile future. I hope I've shown you today that Australian sex ed needs improvement. Fertility should be an important part of that. And I'm working with educators and young people to make this learning effective. There are many factors that can affect fertility, but increasing fertility awareness will create public interest, which has many flow-on effects in our society. It will break barriers and taboos around fertility. It will help people have the families they want. It will lead to investments in medical research, so myself and my colleagues can continue to develop treatments and cures to infertility instead of using assisted reproductive technologies as a band-aid. It will build advocacy for child-friendly social policy so people can have better maternity, paternity leave, flexible working hours and better childcare. And understanding our health gives us a better relationship with our bodies, which is a really great thing. So ultimately what I want is a world where people can choose to have children or not by choice and not by circumstance. And family planning and decision making about, what your future will be is a really empowering thing for a woman to have throughout her life. So that's it from me. I want to say thank you to the research team, including Kath, who's here today. A special thanks to Jessie Sutherland, who couldn't be here tonight. And thank you to Family Planning New South Wales and Cooper Surgical, who fund this research. Thank you.
Thanks so much, Emma. You've really demonstrated there how empowering young women and girls with information and good quality information is so important. So our final speaker for tonight is Professor Deborah Loxton. Professor Loxton is co-director for the Research Centre for Women's Health, formerly the Research Centre for Generational Health and Ageing at the University of Newcastle and here at HMRI. She's also Deputy Director of the Australian Longitudinal Study on Women's Health. Professor Loxton is a prolific researcher, an expert in the impacts of violent relationships on women, as well as different aspects of reproductive health. Welcome, Deb.
Thank you, Kath. You're such an attentive audience. Do you need to have a little bit of physical activity, warm up a little bit? I'm going to change pace a little bit and talk about last year, which was an interesting year in all the wrong ways. So from April to November last year, we surveyed the women who take part in the Australian Longitudinal Study on Women's Health to find out how they were doing. And the women in our study really rose to the challenge by completing 14 surveys over a 6-month period. The Australian Longitudinal Study on Women's Health first collected data in 1996 from about 42,000 women who were then aged 18 to 23, 40 to 45, and, 45 to 50, and 70 to 75. These women have participated in the study now for 25 years, this year being our 25th anniversary. In 2013, we recruited a new cohort of women, around about 17,000 of them, also from across Australia, then aged 18 to 23, to carry on providing information about young women's health. You can see there that there's a beautiful picture that was actually drawn by the study director, Professor Julie Biles. This will be the birthday card sent to our participants who turn 100 this year. The first of our participants born 1921 to 26 will turn 100 starting next month. So they will receive this card when that happens. Our COVID-19 surveys were launched at about April last year. So this time last year, we were locking down. Everyone in HMRI was going home to work from home. And I decided that we weren't busy enough. And so with a lot of enthusiasm, our team decided that we would put together an online survey protocol to see how our participants were doing. This was a unique opportunity to collect data to help inform health policy during the time of the pandemic, an unprecedented time for women in Australia. We decided the 1921 to 26 cohort would be left alone, largely because we weren't able to print surveys and send to them. We did, however, manage to get surveys online for our youngest 3 cohorts. We wanted to keep the surveys short so that we didn't add to the burdens of women in this difficult time. And so we had 1 theme per survey, kept the completion time down to about 2 minutes, and then provided a free text option at the end. So basically saying, is there anything else that you want to tell us about this time in your life? You can see here the topics that we covered over the 14 surveys. We asked them a lot about their financial stress and employment, because these were things that were happening at the time, and I'm sure you can all remember all of the press around people's employment and the difficulties they were having with homeschooling and so on. A lot of these topics were driven by the women themselves. So when we received comments from women that they were experiencing difficulties in obtaining their contraception, for example, we added a question or a set of questions about contraception to the 10th survey. And a lot of those things you can see there actually came about due to the things the women themselves were saying. Today I'm going to focus on 2 things. This, the most surprising and concerning result that we had, not only in the first survey, but with every survey that we sent out over the 6-month period, and also mental health, which was a great concern to both to the women and for the women who were completing the surveys. So 3 in 4 women across all cohorts who reported having flu-like symptoms did not get tested for COVID-19. This was as true in April as it was in November. So you can see there's 74% of those who were in their late 20s, 77% of those in their 40s, and 78% of those aged 69 to 74 had symptoms and didn't get tested. Why didn't they get tested? Well, we had a look at the free text comments to see what was going on, and we found that there were 4 main reasons why people didn't get tested. The first was denial, such as this first comment will give you a bit of an illustration of. I had a cold. It was obviously a cold, no fever, no dry cough, just a head cold. And the way people treated me was horrible, telling me to go home, that I should be tested, etc. The paranoia is understandable, but not welcome. Access issues were also common. As this woman wrote, I have looked into being tested, but it isn't clear where to go at the local hospital. And if I have COVID, I don't want to just wander around the corridors. And the current wait to get into my doctor is 3 weeks. Previous poor experiences in having COVID tests also drove people not to have further tests. So this woman wrote, the test for COVID-19 was awful and I cried. I found the process of booking a COVID-19 test negative. The phone number wasn't working, the website wasn't working, and when I tried to explain this, they were rude and cut me off. And finally, fear. This was a very common reaction. This woman wrote, I was really worried I will get it, but much too afraid to be tested in case I don't have it and then I get it at the testing centre. Fear, denial, access problems and previous poor experiences all drove women with symptoms to not get tested. So I'll turn now to talk a little bit about stress. Stress was extremely high among the 2 younger cohorts. And you can see here, if I can get, does that pointer go up there? No, so look at the top line. And you'll see around about 25% of women who were in their 20s, and between about 20 and 15% of women in their 40s reported very high levels of stress throughout the study period. So along the bottom we have surveys 1 to 13, and these are the stress levels throughout. Stress was very stable for women who were in the oldest cohorts, so in their late 60s and early 70s. Only around 3% of those women were reporting very high levels of stress. Again, we turned to our qualitative data to see what was going on for women in the different cohorts. And we found what you probably are expecting, and that is that women in the younger 2 cohorts had multiple roles that they had to deal with that were then added to, not just by the pandemic itself, but by the policies put in place to control the spread of the pandemic. And I'm sure a lot of you have seen in the media recently research that has shown the disproportionate burden that fell to women throughout last year when it came to dealing with COVID-19 and stopping the spread of the pandemic. So, for example, this woman wrote, "I'm a teacher, my workload may be from home, but it has definitely doubled." Another woman, "Having to work more hours to cover nursing shifts in my department." Other women wrote about experiencing stress with their job security, as you can see by the top quote, and also with social distancing. So some women found social distancing to lead to isolation that they found highly stressful. Other women found it more stressful going back out into the community after lockdowns had finished. So we also have a look at psychological distress. These data were captured at about week 10, which was in about week 5, in June last year. In results that echo the results for stress, we found that women in the oldest cohort were the least likely to report psychological distress, and those in the youngest cohort were the most likely to be experiencing psychological distress. This is actually a measure called the K10, and when women report high or very high levels of psychological distress on this measure, it actually reflects the presence of a highly problematic condition such as depression or anxiety, something that is diagnosable. You can see from these results that just under 40% of women in their 20s were reporting high to very high levels of psychological distress. Around 20% of women in the cohort born 1973 to 78 were reporting high to very high levels of psychological distress. Most women were experiencing the onset of illnesses they had previously experienced when it came to psychological wellbeing. So as this woman wrote, "I have not been depressed in years. This shutdown has brought it all back. I feel anxious, depressed, sad and angry all of the time." They also experienced the worsening of conditions that they already had. So, for example, "I have a mild anxiety disorder that has become exponentially worse during this period and has introduced sleeping issues, mostly insomnia, which I have never previously experienced." And so we also found that many women had sought mental health information during this period over the internet and from health professionals. In fact, 40% of women aged 25 to 31 had sought information about mental health during the 6-month study period. 19% of women in their early 40s had sought mental health information, and only 3%, as you might expect, of women in their late 60s and early 70s had sought mental health information. For those women who actually sought to go and use a mental health service, there were further problems they experienced. 68% of women in their 20s said that COVID-19 had impacted adversely their ability to access mental health services. 58% of women in their 40s and 47% of women in their late 60s and early 70s who tried to access mental health services experienced difficulty in doing that. These are some of the issues they reported. Appointments had been changed to telehealth. There were appointment delays, appointment cancellations. They were unable to access needed medications, and this is particularly important for women with psychological health problems. You can't just skip psychoactive medication. It can make you very, very and dangerously ill. And then a group of women there, just under 10%, saying they were unable to access any of their needed mental health services. These are some of the things they said about trying to access mental health services. "I want to go on antidepressants, but I am unable to do so until FaceTime doctor appointments become available." So while it was possible to get telehealth appointments, it was difficult to get some prescriptions under telehealth if you hadn't had a previous appointment with the doctor about that issue. This woman wrote, "I tried to make an appointment with the psychologist. I researched in June, only to be told she's booked out until next year." And in fact, a colleague of mine in Melbourne, who is a psychiatrist, was recently celebrating the fact that she'd got her wait list down to 350. There were also difficulties with telehealth consultations. And if you imagine that you want to go and talk to someone about your mental health, you don't want to be meeting that person for the first time on a telephone or online. This woman wrote, "When you have telehealth consultations, I don't get the same relief as face-to-face, because when you suffer from depression at times, one needs to see the other person." Despite all of this, and despite the large stress and huge work burdens that women wrote about carrying last year. We also found the strength of women shining through, as we often do when we look at our qualitative data. Women had often taken advantage of the lockdown periods to reflect on their lives and to enjoy the extra time that this had granted for some of them. This woman wrote, "I felt privileged to have been able to spend more time with teenage children and to feel more connected to them. I enjoyed knowing more about their high school studies and curriculum and to be of some assistance. I enjoyed having less pressure to be doing things. It reaffirmed my very good choice in life partner," which I know is very fortunate. A woman in the 1946 to 51 cohort wrote, "It has been a very trying time for all of us. We are surviving because of love and support from family and friends." And in fact, one of the themes that came out for women in this age group was that they felt isolated and alone, particularly in lockdown periods, and missed the feeling of human touch. However, many of them had risen to the challenge by learning to use technology, using things like FaceTime and Zoom for the first time to stay in touch with family and friends. I'll finish with this quote from a woman in the 1989 to 95 cohort. She said, "So far, I am coping better than I expected mentally. I'm bored and miss my work, family and friends, but I'm okay. I'm trying to keep my expectations of myself reasonable and fairly low, and keep busy." I would like to thank the team here who went over and above the call of duty to get these surveys launched during the lockdown period last year. The Department of Health for funding the longitudinal study, and HMRI and the University for funding the COVID studies that went out last year. Thanks.
Thanks so much for that, Deb. It's really important to acknowledge just that extra burden that women faced last year, but the strength that they have as well. So thank you to all of our presenters for your time. You've shared your time so generously and preparing for this night and being here this evening and giving us such great insights and information. We'll now be taking some questions. We don't yet have any online, so feel free to keep bringing those in if you've got any. And if in the audience as well, but I might make a start if you don't mind and let the audience have a little think first. And I'm going to start by asking Nicole a quick question about you found that particularly in the high school age students, they weren't as sure that the school uniform, the sports uniform, would encourage them to be physically active. And I wonder if you had any insights into other things that might be able to be done for that group.
Yes, I think it was actually the younger
Okay.
primary school students, which was surprising. And I think maybe it was because, we surveyed children from K to 6. The little ones probably just don't know any different. It's just they're okay to be flinging themselves around in a skirt on the monkey bars. But probably by year 4, 5 and 6, where we definitely did see an increase in an association between girls wanting to wear their sports uniform, it's probably when they're starting to think about modesty a little bit more. So.
Yeah. We might have a question up the back from online.
Yes, this one's for Emmalee. So, Carla, on Zoom, you mentioned in your presentation that the young mother birth rates have dropped by 40% in the past few years. Can you explain why that is?
Yeah, I actually looked into this and it seems to be an uptake in hormonal birth control and not an increase in teenage abortions. So I hope that answers your question, but that's all the information I have.
And what about in the room? Do we have any burning questions here? If you want to put your hand up, we can bring the microphone to you. Okay, I might ask another question then, this time for Deb in the hot seat. You did mention a few of the really uplifting stories from the participants. I wonder if you had any others to share around that, some other good news stories that you uncovered.
I think that there were very many good news stories included, and I suppose in 11 minutes I overly focused on the negative. So what was amazing to me was how women were able to pivot before politicians even coined the phrase. And so women were already planning on how they would homeschool their children. They had already had everything in place in order to do that before it had even been ordered. They rose to these challenges with amazing grace that I it just astounds me always, the strength of women. Kat's heard me say this repeatedly for a long time now, but the strength of women shines through in times of adversity, and they are the nation's greatest unpaid resource when it comes to dealing with things like pandemics. And I think there is a certain amount of taken for grantedness that comes with that. The women themselves, when they're writing about these things, they don't complain about that. They, for the most part, got on with the jobs that were given to them. But I think that the mental health burden that's come along with that is significant and something that we actually need to watch as we move forwards, particularly with the younger group. So the younger group now will be in that age bracket where they're starting to have children. I think the mean age now for having a first child is about 31.5, 31.6. So we know the greatest predictor of having mental health problems when having children is previous mental health, and we have around half of that cohort reporting a previous experience of depression or anxiety. You asked me for good news stories and I veered off. I do apologise. However, we know that there are some good things in place now, like standard screening for women who are having kids and so on, and we just hope that the referral pathways are sort of up to it to deal with that. I just will keep coming back to the strength of women and their ability to pivot and respond to the demands that have been placed on them. And I would just caution that we can't continue to take women's labour for granted.
Well said. We have another question here.
I have a question for Deb, please. Putting you on the spot, the amazing information that you gather from the study groups, how is that used? So could you give us some examples of where that data is then taken and some of the things that it may have led to over the years? So the study is, as I said, funded by the Department of Health, and one of the reasons is to inform the development of the women's health policy that drives women's health care across Australia. So each year we deliver a major report, this year on reproductive health, and we also have delivered 13 reports on the situation for COVID. The mental health results are currently being examined in more detail for the Mental Health Commission at their request. That report will be delivered next week. That was an urgent job in response to some of the findings that we and other people have had about the urgent need to deal with the mental health impact of COVID-19. So the study itself over the 25-year period has informed 2 women's health policies, policies on alcohol use during pregnancy, on other health behaviours, on incontinence. So there's a national incontinence strategy that was informed by the study. The international guidelines for diagnosing PCOS were based largely on the epidemiology that came from this study. I could go on and on. Does that answer your question?
And we have another question online as well.
Yes, this one is for Deb too, and also comes from Deborah on Zoom. And she asks, in relation to the stress of COVID, why do you think the coping mechanism is better in older women? Is it because of life experiences or...?
So I would have to say that what we notice from looking at the qualitative data is that women's lives in their late 60s and early 70s seem to be more stable and less prone to external influences of employment and the need to look after and educate children. They were also less likely to have had to have moved house, for example. So women in the youngest cohort often wrote about changing living situations, so they had to move back with parents. Interestingly, for the women who are in their 40s, they experienced both older children moving back home, those who'd had their children young, and their parents moving in as well when they pulled them out of aged care and so on. So very much the sandwich generation.
We've got a few questions here on the floor. Maybe while the microphone's coming down, Nicole's got a... Yes?
Can I ask a question?
Please.
So this is for Emmalee. I'm just interested, you showed that screen of all those number of apps that are available. So how do you develop an app that will cut through and be the one that adolescents or women will use?
Well, I think my plan that I hope to achieve. So, as I mentioned before, a lot of apps work with scientists to give us their data. So, I think one of those really popular apps would be on board for being accredited because some of them are verified contraceptives in different countries. I haven't checked if any are in Australia, but if they would like to be, I think it's in their interest to work with, the government or universities to actually get some kind of verification. So I definitely think it starts with something that's already big, because I think starting from the bottom with no reviews, no downloads, then the algorithm doesn't favour you.
Yep.
So yeah, definitely working with a very popular app.
Yep, brilliant.
Hi, Nicole. At my daughter's school, I find it's the parents that are clinging to the tunics and keeping the tunics. Is there a plan to, I guess, target information for parents with all this research you're doing and the findings you're coming up with?
Yes, definitely. So I have absolutely heard the same thing, that parents like to see their daughters look cute in a dress, they look pretty. And so I do definitely think we'd need to be doing some awareness raising around it. I mean, I was actually surprised that 80% of parents were like okay with changing the uniforms, but it could be that last 20% that are the hard ones, they might be the vocal ones that we'd really have to get on board. So yes, we'd definitely be looking at communication strategies of how we try and pitch this, and looking at research around the benefits that if the children are more active, then they might have more concentration in class, better academic outcomes. So I guess, but I'd be interested to hear what would help parents be the sales pitch to them.
We've got a question down the front, and maybe while we're bringing the mic down, we might ask another online one. Is that what we're doing? Yes? Okay.
This is another one for Deb from Zoom. Have you noticed smoking rates amongst women dropping due to COVID dangers?
So we did ask women about smoking during COVID. Some started, some stopped, most stayed about the same.
Another question from the floor now.
Hi, this one's for Emmalee. I was just wondering, please, when you talked about surveying high school kids about what they wanted in their sex ed curriculums, I was wondering if you noticed any gender divides or any really strong themes coming through.
I haven't actually done that research yet. So we are planning to talk to young boys and young girls. So that is something we're really interested in. And just for me personally, I think it's important that young people aren't separated when they learn about sex ed, that everyone learns about everyone else's sex ed, because, you might find someone in your family or your future partner struggling with fertility or their reproductive health, and you actually having that understanding of them is really important for your relationships in your life. So I'd be interested to see that too.
Do we have any other questions from the floor? We do.
Emmalee, also for you, I was wondering what about fertility you think that kids should know, and what should be changed in the curriculum?
So I think, first of all, knowing, because age for women especially, but also for men, is a major factor of infertility, knowing that, you won't be able to have kids your whole life. Some people can't have kids when they want. Kind of knowing about what signs to find in your body when things might be indicating infertility, like, missed or irregular periods. Some young people think if they don't get their period for a while, they're really happy because it's a bit of a burden. So just having that fundamental understanding of what is your reproductive health like, what is normal for you, and knowing what you can expect throughout your life. I think that holistic perspective of reproductive health is what I'd like to see.
Thank you.
I would just add to that, I think young people go from wanting to prevent pregnancy to very quickly changing their mind and wanting to have a pregnancy, and it's a very strange time of life, and having so much information available is so valuable at that time. We've got another online question.
And this one's for Deb as well. So does the Longitudinal study plan to have another cohort for women born after 1996?
So our youngest cohort at the moment are born 1989 to 95. I reckon in about 2 years we'll start petitioning the Department of Health for some money to get the next cohort. We are still very fortunate that in our cohort born 1921 to 26, we have about 600 or 700 participants who continue to provide data to the study even as they are turning 100. They are an amazing group of women.
Do we have any other questions from the floor? We might have another online one, I believe.
This one's for Nicole. Did principals indicate why they were not as accepting of the sports uniform being worn every day?
Yeah, so I think I mentioned the biggest barrier was that they didn't think it was appropriate for formal occasions. Another barrier was, and Alex is sitting in the audience, she might have to help me here, but I think the other biggest barrier was they didn't think parents would like it, and so our data sort of was able to, I guess, counter-argue that, and they were worried about the cost. And so I guess we'll be looking at, if currently parents are buying a formal uniform with black leather shoes as well as a sports uniform, we hypothesise that it's cheaper just to be able to have, one sports uniform and not the drama of remembering each day, is it sports uniform today or normal uniform? Might take it a lot of stress from families, I'm hoping.
I'll do one last roundup if anyone else has any other questions.
Can I ask one more question? Sorry, Deb, this is going to punish you. So the results around telehealth were really interesting, and women saying that was actually a barrier, but I'm guessing telehealth is here to stay. So what strategies what advice do we either give policymakers or those in government about telehealth, or strategies we can give women to address that?
I think telehealth was a problem particularly for women who are having psychology services with a new provider or psychology services for the first time. As I said, forming that relationship can be very difficult. I think there is probably a need for some practitioner training as well as perhaps a little bit of a how-to guide for people who are accessing the service. So something simple that you could send to people for, this is how to get the most out of your appointment. Even though telehealth may not be perfect, it is definitely better than not having a service. And in a lockdown space where people aren't able to do face-to-face, or even for rural living women or remote living women, having access to telehealth can be a real advantage. Yep. I think, though, practitioner training is definitely something that could be looked at.
Yep.
And our last question, I believe, will be another online question for tonight.
This one's for Nicole again. So if a school was interested in the study, are there any size limits, and how would they get in contact with you to take part?
So I can, I don't know, how do I get my email address somehow? How do I do that? I don't know. Oh, they can email here at HMRI and they can put in contact. And no, there's no limit on school size, but we're only going to be looking at Year 4 and 5 students in Years 4 and 5, and you currently have to have a uniform policy where they have a traditional uniform as well as a sports uniform. And be in the Hunter New England region, sorry.
Right, well, thank you so much, Nicole. Thank you, Emmalee, and thank you, Deborah, for sharing your research with us tonight. So thank you so much to everyone. It's such an important area of research and passionate to me as well. And we should really be investing more into it, I think. Hopefully you've gained a better insight about the different areas of women's health and what our research teams here at HMRI are working on, as well as some useful information to help you look after your own health. We hope everyone has enjoyed watching the virtual seminar. On behalf of everyone here at HMRI and our partners at the University of Newcastle and the Hunter New England Local Health District, I'd like to thank you for joining us and for your interest in supporting our work. You can keep up to date on the latest activities via our website and social media channels. Our community seminars continue next month, when the topic will be focusing on the impacts of stroke and research into rehabilitation with Professor Chris Levi. So keep an eye out for the details coming out shortly for that one. And if you want to know more about how you can support our life-changing research, please don't hesitate to get in touch directly via our online contacts or on phone. We'd just love to hear from you. Thank you to those of you in the community who donate to HMRI and support HMRI as a registered charity. Your contributions really do help us to continue our life-changing research. We look forward to catching up with you again, whether it's in person or virtually. Enjoy the rest of your night and stay safe and well, and good night.